My name is Dr. Joseph Chebli. I grew up in Staten Island, New York. I was born in Canton, Ohio. Went to undergraduate at Georgetown University in Washington, D.C. Went to medical school in New York and Long Island, State University, New York, Stony Brook. Went back to Georgetown and did my residency at Georgetown. I finished in 2001, and I've been basically in practice in metabolic and bariatric surgery ever since 2001. So this is my 18th and a half year doing metabolic and bariatric surgery. In terms of what I'm interested in here in Florida, I do a lot of advocacy work on behalf of patients and surgeons in our state, and I'm the state Access to Care representative for the state of Florida to the Access to Care Committee for the society, which our society is the American Society for Metabolic and Bariatric Surgery. I'm the chair-elect of the Diabetes Advisory Council. This is a council that was set up by the legislature, legislatively mandated, and I was originally appointed to the council by then Governor Rick Scott, and then since became chair-elect to the council. My practice is called Southwest Metabolic and Bariatric Surgery. The folder you have has that name on it, and the website address and so forth. So we'll go ahead and get started. So Brandon, a little bit about our site. Brandon Regional is one of the only centers in Florida, or albeit even in the US, that holds every accreditation for what's called Centers of Excellence for metabolic and bariatric surgery. Every insurance designation, as well as our two major accrediting bodies professionally. One is called MBSA QIP. There's a test on this when you leave here today, but it stands for Metabolic Bariatric Surgery Accreditation Quality Improvement Program. Okay, and then the SRC, which is a little easier, is the Surgical Review Corporation. So we have both of those designations, as well as all the insurance designations in the US. So when we talk about obesity, we use this terminology BMI, body mass index. So body mass index normal is considered up to 25. And then you have the classifications of obesity, which start at a BMI of 30. And they go by fives. So class 1 obesity is between 30 and 34.9, class 2 between 35 and 39.9, and class 3 greater than 40. Some people refer to a separate classification, which is class 4, which is called super obesity. To give you a sense of how prevalent obesity is in the United States, about 40% of US adults, which is 93 million people, are considered obese. And it's pretty equivalent between men and women. To give you a sense of what we do in the United States in terms of annual volume of these operations and the epidemic that is obesity, there are some studies that show up to 35 million people in the United States need and are qualified for surgery. And it hasn't varied a lot, but in the last probably 10 years, we're around 200,000 surgeries, maybe a little bit more after that. So we're not penetrating this disease terribly well. So how do we consider criteria for surgery? Well, fortunately or unfortunately, we're still using a very old classification system and consensus meeting system called the NIH Consensus from 1991. We have made efforts on our society level to try to reconvene these consensus because we feel these criteria are quite old and regimented. But in general, the criteria are that people who qualify for surgery have to have a BMI of more than 40 or 35 and higher with at least what we call one high-risk other medical problem, which you'll hear referred to as a comorbidity. And examples of comorbidity are type 2 diabetes, sleep apnea, fatty liver disease, high blood pressure, problems with lipids, cholesterol, and so forth. Those are called comorbidities. We also like to see that patients have failed a diet in the past, that they're psychologically stable, that they're knowledgeable about surgery and its outcomes, that's what today's about, that they're motivated to be successful, and that they have medical problems that do not preclude their likely survival from surgery. So what does that last line mean? What it means is that we're a center of excellence. We have an expectation among all the people who participate and operate in our center and take care of our patients, that everything is done in a very comprehensive, thorough fashion. And that's the most important thing to know. So more and more, we want to refer to what we're doing as metabolic surgery. Okay, so for those of you that don't know what metabolic surgery is, it's a reference to the use of surgery directly to improve certain medical conditions. Now, how does that differ or altered from what people generally know to be these surgeries and calling them bariatric surgeries or hear the term weight loss surgery? Well, bariatric surgery refers to weight. Okay, that's mostly related, weight-related or weight loss-related surgery. And we want to get away from that because that's a very old-fashioned, antiquated model for how we consider what these surgeries do. We want people to know that these surgeries eradicate disease, save lives, extend life, improve quality of life, but most important, directly impact some of the comorbidities that I've already mentioned. And the reason I listed them the way that I did earlier is because those are the key metabolic problems. So the best way to think about this is diabetes. And we'll talk a lot about diabetes. If the last third of this talk is all about what we call diabetes surgery. But it's the idea that when we perform surgery, there are certain very important metabolic changes, hormonal changes that occur. These are rooted in the gut, and they're rooted in the fat that surrounds our organ, we call the visceral fat. And those important changes improve medical problems even before weight loss. Okay? That's the key point more than anything else I want you to leave here understanding. We're not talking about things that get better because of weight loss. And even in our medical community, among our primary care doctors, cardiologists, lung specialists, et cetera, there is still this idea that what we do is operate and people lose weight and then their medical problems get better. That's not how it works. The way these things happen is these important mechanistic, we say, and hormonal changes occur independent and before weight loss. So the idea, again, back to the diabetes example, is someone has diabetes and they have surgery and the diabetes is improved or potentially even what we call in remission, even before weight loss, even in the hospital sometimes. That's what metabolic surgery is about, and that's the most important thing we need to do. We need to get away from people seeing these operations as operations for obesity or weight loss surgery. Now, I'm probably as guilty of as anybody. I'm sure on my website or in my packet, there's mentioned a weight loss surgery. Sometimes we think that maybe that's just easier for people to understand, but I don't think people have a difficulty understanding metabolic surgery when you explain it the right way. And that's the most important thing that we need to do as a society, is to change the way that we consider these operations. So we're going to talk about what we consider to be the 4 frontline operations done in the US. There are others, and we can talk about them, but we're going to focus on the 4 major treatments. And they're all done laparoscopically, which is minimally invasive surgery. That means we use smaller incisions instead of a large incision in the abdomen. And they are adjustable gastric bands, vertical sleeve gastrectomy, Roux-en-Y gastric bypass, and biliopancreatic diversion duodenal switch. So we'll start with the band. So in the band operation, what you see is this is the band, this is the esophagus, and this is the stomach. And the band is placed in a position just slightly below where the esophagus meets with the stomach to create what we call a virtual pouch. And the idea of the band is simple. We tighten the band, we restrict the amount of food that people can eat. This is a portion limiting device. If they're over-restricted, we can loosen the band. And we can do all that in the office without even any local anesthesia. So the band peaked in popularity in the United States in about 2005. Fortunately, it has all but disappeared in terms of metabolic and bariatric surgery. And the reason why I have personally never been an advocate for this surgery, and certainly why I'm pleased to see it go away, is that there are 3 major things about bands that you should know. Number 1, as far as weight loss data is concerned, the band is a lousy operation. Almost 75% of the people who had bands placed in the world failed to lose half their excess weight at 2 years. 2, the band is not a metabolic surgery. It's the only surgery we're going to talk about today that doesn't involve this hormonal mechanistic change after surgery. It is just a portion limiting device. And 3, and probably more importantly, the band creates intensive, frequent foreign body complications, as high as 1 in 3 patients. And in my practice, which is a high percentage revision practice, we spend a lot of time removing bands and taking people and converting them to other operations. So we are not advocates for the band. In the United States, the band probably only occupies the place in most practices now of lower BMI patients who are probably paying for themselves, where the other operations are probably more costly. That's a very narrow indication and usage at this point in the US. So we'll move on. Vertical sleeve gastrectomy, which is the formal medical name of the procedure, VSG, or sleeve gastrectomy, or patients have come to refer to it as the gastric sleeve. They're all terminologies that mean the same thing. Technically speaking, what we do in the sleeve is we remove a portion of the stomach, about 80%, leaving a banana-shaped or comma-shaped reservoir, or half moon. Now, the mechanism of action of the sleeve, although one would look at this and say, oh, I understand, you eat less. Yes, to some extent, there's a limitation in volume of the sleeve, but that's not how metabolically and hormonally this operation works. The way the sleeve works is, the one important mechanism of it is the removal of the stomach removes most of the appetite drive that we have. Okay, that's called the orexigenic drive. That's the drive that motivates us to be very hungry and to eat. The hormone that does that is called ghrelin, G-H-R-E-L-I-N. It's in an article in the packet that I've written. And not all the ghrelin is in the fundus of the stomach that's removed, but about 85% of the body's ghrelin is. So the sleeve is an excellent anti-ghrelin, excellent anti-appetite operation. But there's more to the sleeve than that. This stomach that's left behind has increased emptying function, okay? That increased emptying function is what stimulates the small gut. And that stimulation of the small gut is an important driver of the removal of insulin resistance for a diabetic, for all the factors that are driving the patient towards poor glucose control and diabetes. And there's much more to it than that. But the predominant action of the sleeve is increased gastric emptying, which stimulates the small intestine, the small gut. And that's how a lot of the mechanism metabolically works in the sleeve gastrectomy. The sleeve is nice because it can serve a wonderful purpose in people who are very surgically complicated. So it fits a really nice place in surgery. It has become the most popular operation in the United States. As many as 60% of people who consider first-time surgery now in the United States and worldwide are having sleeve gastrectomy. So it's the #1 most commonly performed operation now in the world on an annual basis over the last 3 or 4 years. The sleeve is and has always been a very useful operation for patients who are very high weight or high BMI. It had its origin in the early 1990s, as early as that, in staging people who had very high BMIs, the so-called class 4 or super obese patients, in terms of performing a sleeve and then seeing how they do and potentially bringing a patient back for then more involved operations. So it was very useful in reducing weight, lowering anesthesia risk score, and potentially setting up a more complicated part of the operation to be done at a later time. That's called staging. We still talk about staging in sleeve gastrectomy patients for anybody who walks in the office whose BMI is 60 and higher, and arguably even in that 50 to 60 range, but certainly at 60 and higher. For all other patients, what we call this is the use of the sleeve as a standalone or single stage operation, like the other operations I'm going to show you. And that can be very useful. The biggest downside of the sleeve gastrectomy, and which is creating a lot of controversy as we get out now over a decade of doing sleeve gastrectomy as a standalone operation, is the amount of reflux that patients can develop, or heartburn that they can develop after a sleeve. That's the biggest downside of the sleeve. There are even studies that show that patients who didn't have heartburn before the sleeve have developed heartburn after the sleeve and have also developed a precancerous condition called Barrett's esophagus. There's a very well discussed, let's put it that way, paper from Italy where a significant percentage of the patients developed Barrett's esophagus who had endoscopies preoperatively and did not have Barrett's. So that's a concern. So there's a lot more to tell you, but I think those are the biggest features of the sleeve, and we can certainly discuss them more as we go into the question and answer. The next operation I want to talk to you about is the Roux-en-Y gastric bypass. This is the operation that for many years was considered, quote unquote, the gold standard surgery. We don't really use that terminology anymore, but up until the advent of the sleeve, the bypass really was considered, quote unquote, the gold standard. In this operation, technically what we do is we create a thumb-sized reservoir called a pouch, and we do a small intestinal reconstruction called a Roux-en-Y. The way this operation works is the emptying of the pouch goes directly into the small intestine, which creates that small bowel stimulation that we talked about in the sleeve gastrectomy. But the additional mechanism here hormonally is bypassing most of the stomach and the upper small gut. And what happens there is there are important drivers of increased blood sugar that reside in the first part of the small intestine called the duodenum that are basically bypassed out of the system. And that's an important metabolic driver of improved metabolism and insulin resistance response, glycemic or glucose or blood sugar response in Roux-en-Y gastric bypass. And I personally think, biochemically, that's why we see the bypass probably has a better profile in terms of diabetes improvement than sleeve gastrectomy. That's at least my own personal feeling based on the studies that I've read. So the bypass is an excellent operation. It's in terms of the spectrum of the surgeries we've talked about so far, it's a better, quote unquote, weight loss producing operation than the band, than the sleeve. It is a better disease improving operation than the band, than is the sleeve. But we're going to go over that detail and of the studies that show that in just a minute. The biggest cautionary problem with the bypass, and the reason why I think to some extent the sleeve got more popular in the medical community, is because the bypass should be more limiting on the patient after surgery in terms of the types of medications that we want people to be taking. And specifically what I'm getting at is we don't love people taking aspirin after gastric bypass. We don't love people taking any steroids after gastric bypass. We don't like people taking any non-steroidal medications after gastric bypass. That's Aleve, ibuprofen, naproxen, and so forth. Why those medications? Because they're also what we call ulcer-producing medications. And the gastric bypass in and of itself, in this reconstruction, in the top part of the anatomy, is potentially predisposes a patient to forming ulcers. So you don't want to combine those two things. So that's not a great combination. So if we see people who are already on those medications or have to be on those medications, we'll potentially dissuade them from gastric bypass. Gastric bypass is not a great choice if a patient has inflammatory bowel disease. For patients who have Crohn's, and I just met a Crohn's patient in the office before I came here, patients who have Crohn's disease, ulcerative colitis, we generally don't love gastric bypass in those patients. The biggest medical downside of gastric bypass, probably across the board, is a special type of complication that can develop that's unique to it. It's called an internal hernia or a Peterson's hernia. And that's a lifetime risk for the patient. And even though it doesn't happen very frequently, it's a downside of gastric bypass. So a patient has abdominal pain, comes to an emergency room in the United States, anywhere in the ER and has gastric bypass, we're always worried that that patient has an internal hernia. And that's a negative of the operation. And if you have a gastric bypass, for better or worse, you're always going to be a patient that's a gastric bypass patient. And that is a little bit different than some of the operations we've already talked about. Next operation I want to discuss is laparoscopic biliopancreatic diversion with duodenal switch, otherwise often known as DS or the switch. In this operation, what you see, if I've done a good job lecturing, which if you're all still awake, is in the upper part of the surgery is a reservoir that is the sleeve. So this is where the sleeve gastrectomy came from. It came from the BPD-DS. What happened over many years was in doing DS, and predominantly by DS surgeons, is some of those patients were intolerant to the long operation, and the operation had to be stopped at the point of construction of the sleeve. And what started to be noticed over time, when you accumulate enough data, enough patients from the 1990s, say to the mid-2000s, is this is a pretty good operation doing all the things we talked about as far as the sleeve. And that's kind of how the sleeve got its infancy and start as a staging and standalone operation. And then you see a much longer type of bypass underneath the sleeve reservoir. The biggest, and this is a great operation, And it's a great metabolic surgery, but it's been around a long time. It originally had a form with a horizontal gastrectomy as the original biliopancreatic diversion in 1979 by a man in Italy named Niccolo Scopanaro. It was called for many years the Scopanaro operation. And then it was modified by a US and Canadian surgeon. They get equal credit for the vertical construction in about the 1990s. So it's been around a long time, but most people have never heard of it because it's not a great lifestyle operation. And even though there are people in our society that are always trying to resurrect this operation and make it more popular, it just won't catch on. And why it won't catch on is a couple important things. Is a lot of protein wasting, frequent bowel movements, and foul-smelling gas. So for people who work and live in society, it can be very debilitating, and it's not a very attractive or pleasant thing for people to think about. And the concept that you're going to have surgery and go to the bathroom a lot is really this operation. People always think it's the other operations we do, but a lot of times it's BPDDS that they're talking about. So it's just never caught on. But as a metabolic surgery, arguably, it's one of the best surgeries. As weight loss data goes and durability of weight loss, it's probably one of the best surgeries that's ever been invented. It's just not terribly popular. There's a variation of this operation now that's coming more and more into popularity called the SIPS, or SATIS, if any of you have heard that. Small intestinal pyloric sparing surgery, SIPS surgery, is the idea of doing a DS after a sleeve, okay, but only with one kind of hookup. That's what's getting a little more talk and a little more popularity. There's more data being published on it, and we're actually pursuing an institutional review board approval to start performing that version of the duodenal switch as a potential staging operation for patients who've already had sleeve gastrectomy. Okay, so next part of the talk is all about safety. You know, it wasn't long ago when people considered bariatric surgery dangerous or even drastic, and there are people probably that still feel that way. We tell people now, based on a lot of the slides I'm going to show you, that bariatric surgery is as safe or safer than gallbladder surgery or hysterectomy. And most people don't think about that. When they come to a seminar, they don't have a concept that that's even possible. But these are the studies that really prove that to be the case. This is a study, the Longitudinal Assessment of Bariatric Surgery lab study, and there's labs too now, that showed that the mortality, the risk to one's life with surgery at 30 days is about 3 per 1,000, which is comparably lower than some of the operations that I just mentioned. This was the very first publication of Center of Excellence data from the Surgical Review Corporation called BOLD. In this study, the 1-year mortality was 1.3 per 1,000. 30 days, 9 in 10,000. This is a study of academic centers performing metabolic and bariatric surgery, comparing it to other general surgeries that most of us have heard about. That's anti-heartburn surgery, appendectomy, gallbladder, colon surgery, ventral hernia, and rectal removal. In this list, the only operation that's safer than bariatric surgery from a standpoint of complications and risk to one's life is appendectomy. All the other surgeries have more risk. And I always ask people at this point of the lecture, who walking in here today would have thought that metabolic and bariatric surgery has less risk than having your gallbladder out? Nobody. Nobody raises their hand. Of course not. But we know that to be the case now. And it's really a credit to the nature of centers of excellence and the comprehensive nature in which we take care of our patients. So next I want to show you some comparative studies that compare the results and disease improvement for sleeve, for gastric bypass, and for adjustable gastric bands. This is a study from Michigan, and Michigan is a very high quality state for reporting data. In fact, our society redid its whole Center of Excellence program based on how the Michigan Collaborative works. So all of you from Michigan, proud people from Michigan, you should be proud. It's a great state for bariatric surgery. This study looked at 3,000 patients in each group. So the risk of complication, serious complication with metabolic bariatric surgery, comparing the 3 operations, are all hovering around that 1 in 1,000 number at 30 days for surgery. The blue is gastric bypass, the light green is the sleeve, and the other olive violet color is the band. Okay? In terms of serious complication, the sleeve and the bypass are similar, about 2.5% of the patients with serious complication. Again, that risk profile being lower than some other commonly performed surgeries. These are the serious complications that most people want to hear about in terms of frequency and percentage. When we go talk to primary care docs and so forth, this is really what they want to see. And these are the most serious complications other than risk to one's life with surgery. Leak, intestinal blockage, bleeding, and blood clot. Okay? And the bypass and sleeve are very similar in their profile. In this study, the leak rate was slightly higher in the sleeve, just under 1% versus the bypass. The risk of bleed that required blood transfusion, about 1 in 100 versus 2 in 100 in the bypass, sleeve and bypass. Blood clot risk, that's pulmonary embolism or deep venous thrombosis risk, of about 1 in 300, 1 in 200 with bypass and sleeve. Risk of obstruction is higher in the gastric bypass, mostly by what we talked about earlier, that risk of special kind of risk of an internal hernia that's specific to gastric bypass compared to the sleeve. Okay? Length of stay in the United States is still around 2 nights with both the sleeve and the bypass. Here at Brandon, 2 surgeons keep their patients 1 overnight, and I keep my patients 2 overnights. So we fall into just over a day here at Brandon Regional. Okay? National rate of readmission after surgery with all surgeries is about 5 in 100, 5%. That's our benchmark, and ours much lower than that. Okay? And we can go over this list in more detail if anybody has any questions. In terms of weight loss, we use this term percentage excess weight loss. You'll see this reported a lot if you look at medical weight loss studies and surgical weight loss studies. What the idea of percentage of excess weight loss is if you have a weight of 200 pounds when you come to the office for your first consult, and you have about 100 pounds to lose, we base everything off that 100 pounds of extra weight or excess weight. So if a patient has surgery and they're a year out of surgery and lose 80 pounds, they had 100 pounds that they were overweight, 80 over 100, or 80% excess weight loss. That's what that term means, okay? So in the US, the average 1 year for percentage excess weight loss in a bypass is the blue, 70%. Sleeve gastrectomy, 60%. When you get out to 3 years, gastric bypass about 67%, sleeve a little bit over 50%. Okay, notice the band patient never loses half their excess weight. This is what happens with disease-specific results in these operations, okay? This is a year. This is diabetes that requires insulin, okay? Gastric bypass, 65% remission, sleeve about 40%. Diabetes that doesn't require insulin, 80% remission in the bypass, 66% in the sleeve. Sleep apnea, 66 and 57%. Bypass and sleeve. High blood pressure in this study, about 45 and 40%. Notice the curves, and this is pretty much how it goes. Bypass, sleeve, band. And later on we do the DS slides for disease remission. They'll go in a similar way, and I'll show them to you. So this is a large comparative study that was published late last year, but about a year and a half ago. And this looked at the band, sleeve, gastric bypass, and the duodenal switch. And this looked at BMI drop instead of percentage excess weight loss. Okay? And this is very important to orthopedic surgeons who are trying to do total joint arthroplasty, joint replacement, because it's very important that their BMIs are below a certain threshold. So I like talking about BMI personally more than weight. I think it's more reflective of what happens with our disease processes. So the added color in this now is the duodenal switch, which is in this kind of bluish purple. Now the gastric bypass is in this olive color, the sleeve in green, and the band in this, I don't know, is that more of a royal blue? Okay, so 20 points at a year with the DS, 15 or 16 with the bypass, 13 with a sleeve, 7 with a band. This is the ratio of disease remission, all compared to the band, which is because it's benchmarked at not being very good is on the denominator. So you see that the best operation for blood pressure, duodenal switch, slightly better than bypass, better than the sleeve. For sleep apnea, the bypass is slightly better than duodenal switch, better than the sleeve. Diabetes, duodenal switch, better than bypass, better than sleeve. Heartburn, the best heartburn surgery, gastric bypass, slightly better than duodenal switch. And actually, it's the only study in which anything falls below the band. The sleeve, like we talked about with the reflux, actually worse than the band for reflux. Okay, and then musculoskeletal disease, gastric bypass, then duodenal switch, then sleeve gastrectomy. Serious complication risks. It goes usually inverse to the other curves I showed you. So generally, the better the operation, the better the BMI drop, the more potentially complex looking the operation, generally the higher incidence of complications, but because there's more to do in these operations. So the incidence of serious events, okay, these are at 30 days, duodenal switch, higher than bypass, closer to the sleeve, and then the band, okay? And these are the individual ones for bleeding, leak, and pulmonary embolism. And all follow that same trajectory. And the same thing at about a year. Okay? So life expectancy. This is the most important part of the talk. Life and death. What is the difference between needing surgery and having it, and needing surgery and not having it? And these are the most important studies. This one was done in Canada. It only had gastric bypass patients involved in the study, and they looked at 5-year rate of death in patients who had surgery and those who needed it but didn't have it and were managed in intensive, what we call medical lifestyle intervention program. So they weren't just not operated on, they were treated medically. At 5 years in this study, the risk of death was 6% at 5 years in the medical group. It was just over half of 1% in the surgical group at 5 years. So we say that the relative risk reduction of mortality, 90% with surgery. This is the most widely referenced and quoted paper in scientific literature with regard to our field, metabolic and bariatric surgery. It's from Utah, looked at 8,000 patients who had a gastric bypass and 8,000 patients who required surgery who didn't have it. At 7 years, the patients were followed up. The overall mortality decrease at 7 years was 40% in the surgical group compared to the medical group that needed surgery and didn't have it. Now, more importantly, when you look at the disease-specific results, if you had diabetes and you had surgery, you reduced your mortality by 92% compared to people who had diabetes who didn't have surgery. If you had any history of cancer, the reduction in mortality was 60%. Any history of coronary artery disease, 56%. In the Swedish obese subject study, which is the largest comparative study that's been going on in medicine, it's going on its fourth decade now, a 30% reduction in what we call all-cause mortality at 11 years following surgery compared to people who were managed medically. Again, intensive medical lifestyle intervention. This is a study from South Carolina, again focused on diabetes patients who had surgery, okay, compared to diabetics with severe obesity who didn't have surgery. And the metabolic benefit, the mortality benefit in this surgery, 67%. So when we go in front of people, and I go in front of important policymakers, and I only have like 2 minutes to talk to them because they have a very short attention span, what do I tell them? That surgery is the most effective treatment. We've seen those studies, the remission of diabetes with surgery, and I tell them that the mortality benefit is between 67 and 92% with surgery. And that's basically all you're going to get to say, but those are important things for them to understand in a short period of time. In the last part of the talk, we're going to talk about this concept of diabetes surgery. And the most important thing that happened in diabetes surgery happened in this global summit that's just from a few years ago. This was the third international effort to get the entire medical community that cares for patients, who were mostly non-surgeons, to understand how to start using surgery to treat diabetes. Okay? That's the concept I want you to leave here with. Diabetes surgery. And remember, when people think you're confused and you know what you're talking about, remember to explain to them what we're talking about is you have surgery and your diabetes improves, and it's not because of weight loss. You can go out, you can spread that word. It's very, very important because no one in society, even in the medical community, either cares to learn that or understand it. And it is critically important because diabetes is our biggest problem in the United States and all over the world. But the summary of this summit was that we should start using this concept of diabetes, metabolic surgery, anyone with a body mass index that exceeds 35. And we should even strongly consider surgery for people who aren't being controlled, who have a BMI over 30. Remember when I said earlier that NIH criteria was kind of old? Make a lot of sense, and this is why it doesn't make sense, because diabetes surgery should be done for people starting with a BMI of 30. But the NIH consensus data is so old, it doesn't encompass for that. These are the 11 randomized controlled studies. These are the highest level studies in medicine that all demonstrate the superiority of surgery to intensive medical lifestyle intervention. And then they're compared to each other in some of these different studies. I'll just highlight a couple of the ones that get the most attention. There is the so-called Stampede trial. If you're diabetic and you come to see me in a consult, I will write on your inside jacket, Stampede in capital letters, because I ask patients to go and look up the study. So the Stampede trial, the data of which is out to 5 years now, which shows the difference between a sleeve and a gastric bypass and medical treatment. And at 5 years, it's about 29% remission of diabetes for the bypass, 23% for the sleeve. So at 5 years, it's close. But there's one thing about that study. The more you liberalize the A1C, so for any of you diabetic, you'll know what I'm talking about, and you're not so strict under 6%, because most people don't use 6% as the goal, they use 6.5 or 7, the discrepancy between the sleeve and the bypass widens, where the bypass, just like the other studies I showed you, is a better diabetes operation than the sleeve. The other one that I should mention is the Monroe study, which really is the Rubino study. He wished that he'd put himself first instead of at the end. Principal investigators and scientific papers are usually at the end. In this study, he wished that he was in the front because nobody ever mentions him. And he's a brilliant guy who's done all the research and discovering how it is that surgery works for diabetes. But that study looked at bypass and the duodenal switch at 5 years. And you see 68% remission with a DS, 42% with a bypass. And then look at all these studies. Look at the medical remission rate. Is anybody seeing these round numbers of 0? No remission with intensive medical lifestyle intervention. So how do we summarize? Very important few points. 11 randomized controlled trials that all demonstrate the superiority of surgery over medical lifestyle intervention for diabetes. Why are we waiting to treat diabetics with surgery? If you can figure that one out, you let me know. But it is critical because we like to say 3 things. There has been an inexorable and unsustainable increase in the global expenditure regarding diabetes. Type 2 diabetes, along with obesity, may yet be the greatest chronic disease epidemic in the history of human existence. This statement is the lead statement in our Diabetes Advisory Council published report, 2019, for the whole recommendation section for diabetes, not just about surgery. And it's the lead statement that it's the greatest disease challenge that we have in human history. And this is my career, because I told you earlier, I finished in 01. There has been a meteoric rise, greater than 2-fold increase in diabetes globally. There were 150 million diabetics when I finished my residency in 01. Now there are about 500 million. So what does it look like? And this is all data from the American Diabetes Association. 30 million diabetics in the United States at a cost of 1 in 3 Medicare dollars. In the US, in total insurance costs, 1 in every $5 spent on diabetes costs. And the number of diabetics is going to go up by 2030 to 2050. There's been a 41% increase just over a 5-year evaluation according to this study of the American Diabetes Association. Florida now is second to only California in diabetes costs. When I moved here and presented to the Diabetes Advisory Council when I first became part of the council, this slide, I showed this slide. Florida, $18 billion costs. Okay, I joined the council I think in 2015, 18.9 billion. In the report you're going to read, if you read it, and you should, the published report, do you have any idea what the cost is now? It's over 25 billion. I've only been in Florida for 6 years. The cost has gone from 18 billion to 25 billion. And we still don't have a legislature that mandates insurance companies and county people and all the people who are insuring our patients to cover surgery for diabetes. And yet, they don't know where the money is. But anyway, that's as political as I'm going to get today. Okay. So, what do we know? And this is the only thing they respond to. We know these operations are cost effective. And we've had to do these studies to show that. One study that showed that per 1,000 patients over 10 years, that you save direct cost savings of $2.7 million. And if you include the direct and indirect costs, you save about $5.5 million per 1,000 patients over 10 years diabetes. There was a recent study from last year that showed a 10-year savings, same thing if you look at the 1,000 patients, of about $1.5 million for those same 1,000 patients. The International Diabetes Federation position statement, which came before the DSS-2 study, estimated the cost per individual is about $300,000, give or take, per individual diabetes. We have 30 million people in the United States who have type 2 diabetes at about $300,000 per individual. Who can multiply a lot of zeros quickly? $9 trillion in current costs. Projection of populations in diabetes by 2030 to 2050 makes that $9 trillion escalate to somewhere between 18 and $27 trillion. Does anybody like to watch the news and see that debt clock? You know, when they show the debt clock, like every 5 minutes the clock's going? Well, guess what? That's more money than we're in debt in the United States. And that's just the cost of diabetes. It doesn't include anything else that's near and dear to our hearts, whether it's autism, multiple sclerosis, cancer, I mean, you name it. Bridges, roads, schools, anything, okay? We don't have any money for anything else in society except for diabetes soon. And yet we still don't use surgery to treat it, even though it's the most effective life-saving treatment. So this is my surgical experience. I've done, on Monday, I'll have performed my 2,000th operation in my career. And I've done about 1,000 gastric bypasses, just over 500 sleeves, 160 bands. We also offer gastric balloon surgery, and we do, like I said, a lot of revision operations. So that's what we offer in our practice. Thanks for bearing with me as we went through the talk. I'm glad you're all still awake, and I would appreciate now any of the questions that you have or clarifications on any of the slides.